see the beta-lactam ring here, and it is attached to hydrothiazine ring. Okay, it is attached to a dihydrothiazine ring. Cephalosporin was first isolated from a culture of Acrimonium strictum from a sewer in the Sardinia in 1948. So that fungus name is your Acrimonium, and it was isolated uh, from this Acrimonium strictum from a sewer in Sardinia. So this in 1948. This Sardinia is a small Italian island in the Mediterranean Sea, and it was isolated by Italian scientist named Giuseppe Bracciu. Okay, so Giuseppe Bracciu. So this was the scientist who first identified these substances. He observed these substances produced an effective substance which is effective against the Salmonella typhi, and this Salmonella typhi is a causative organism for typhoid fever. So it was first identified, and it was named as Cephalosporin C. So let's see about the classification of cephalosporin. So before going into the classification, let me remind you, as this is a beta-lactam antibiotic, so mechanism of action will be similar to that of the penicillin. So what was the penicillin mechanism? Penicillin was able to bind to DD transpeptidase. This is a penicillin binding protein. So this same like cephalosporin will also bind to this DD transpeptidase, and it will inhibit the cell wall synthesis. It will inhibit the cell wall synthesis. Okay, and this resistance against penicillin is similar to that of the resistance against cephalosporin is similar to that of the penicillin. So such as number one is production of beta lactamase enzyme by some of the bacterial species, and second one is your structural changes in the penicillin binding protein, and the third one is structural changes in the porine channels. So these cephalosporins are unlike penicillin. The cephalosporins are also effective against the gram-negative bacteria. So they may enter through the porine channels inside the gram-negative bacteria, and they may stop the cell wall synthesis there. Okay, so if there is a change in that porine channels, so this cephalosporin will be unable to enter the gram-negative bacteria. So these are the three resistance mechanisms so far has identified. So after this, let's quickly see the classification of the cephalosporin. So cephalosporins are generally classified into different generations. So as the generation increases, the activity against the gram-negative bacteria increases, but unfortunately, the activity against the gram-positive bacteria will decrease as the generation increases. Okay, so the first generation, let's see the first generation drugs. So through oral route, we can give cephalexin and cefadroxil. cefalexin and cefadroxil. Troparenteral, we can give cefazolin. In second generation, the oral drugs are cefaclor and cefuroxime, and the parental drug is your cefoxitin. In third generation, you have oral drugs like cefixime and cefpodoxime and cefdinin, and the parenteral drugs like cefotaxime and ceftriaxone. In the fourth generation, you only have parental drug like cefepime and cefpyrome. And in the fifth generation, you have parental. This fifth generation is the newer cephalosporin, and you have parenteral drug like ceftaroline physomil. So these are some of the classification of cephalosporin. Now let's quickly jump on to the antibacterial spectrum. Antibacterial spectrum. So these cephalosporins are generally active against your staphylococci, and most of the streptococci. But they are not this first generation cephalosporins are not active against the enterococci. Okay, so this is regarding the first generation. Let's see about the second generation. For second generation, they are generally active against the gram positive as well as the gram negative, such as your Haemophilus influenza and Neisseria gonorrhea. So, and this second generation cephalosporin can also cross the blood-brain barrier. This is your second generation. And regarding the third generation, they have improved beta lactamase activity, and they can penetrate through the cerebrospinal fluid, and they can be used in the treatment of meningitis. Okay, and this third generation cephalosporins are having a greater gram negative activity than the other two cephalosporin generation, that is first and the second generation, and they are effective against the gram negative bacteria like Enterobacteriaceae, influenza H influenza, Neisseria meningitis. These all are gram negative. These all are gram negative bacteria, and this cephalosporin ceftazidime. This is a third generation cephalosporin which is having very good activity against the Pseudomonas species. Pseudomonas species. And this third generation, all the cephalosporin, third generation cephalosporins are less effective against the gram positive bacteria. Okay, they are less effective, less effective against the gram positive. Now let's go to the fourth generation. The fourth generation, they are generally active against both gram negative and gram positive bacteria, and they are also effective against the sensitive strains such as Staphylococcus aureus. but unfortunately they are not effective against methicillin resistance Staphylococcus aureus. So they are already I told you most of the active against they are most active against most of the gram positive as well as gram negative, and they are also active against sensitive species like Staphylococcus aureus, but unfortunately they have no activity against methicillin resistant Staphylococcus aureus. Then drugs such as the drugs in the fourth generation such as your cefepime is having very good activity against Enterobacter. Okay, then this very good activity against Enterobacter, which was not seen in your third generation. This third generation cephalosporin were not showing any good effectiveness against this Enterobacter, and this Enterobacter was resistant to this third generation antibiotics. Okay, so this is your about your fourth generation. The last one is your fifth generation. Fifth generation cephalosporins are effective against both gram positive and gram negative, and especially this drug ceftaroline. It is effective against the sensitive species such as methicillin resistance Staphylococcus aureus. So it is a very good drug for methicillin resistance Staphylococcus aureus. So this is about the fifth generation. So this is some of the spectrum of activity of the cephalosporins. Now let's quickly move on to the clinical use of cephalosporin. Clinical use of cephalosporins. So generally it is effective against your, it can be used for the treatment of septicemia. Sorry, it is used for the treatment of your septicemia. Cephalosporin can also be used for the treatment of pneumonia caused by susceptible organism. It can be used in the treatment of meningitis. It can be also used for the treatment of biliary tract infection. It can only be also used. It can also be used for the treatment of urinary tract infection, and it can also be useful in the treatment of sinusitis. So these are some of the clinical use of cephalosporin. Regarding the adverse effect, it is usually similar to the cephalosporin. So it may cause hypersensitivity reactions like penicillin used to cause hypersensitivity reaction, which you have observed during in case of penicillin also, and it may cause pain in the place of intramuscular injection. And there may be some cross sensitivity. About 10% of penicillin sensitive individual will have allergic reaction to cephalosporin. Okay, so cross sensitivity. So about 10% of penicillin sensitive individual, 10% of penicillin sensitive individual will have allergic reactions to cephalosporin also. Okay, so number three is your nephrotoxicity. It may cause nephrotoxicity. Cephalosporin may cause nephrotoxicity. Especially it has been reported in case of drug your cephalosporin such as cephadrin. Okay, so nephrotoxicity has been reported. Number four, it may cause diarrhea. Okay, so diarrhea is common and can be due to the species of bacteria known as Clostridium difficile. Clostridium difficile. So this Clostridium difficile is generally present in our colon. Okay, so when taking the cephalosporin, it will be present in our colon in an inactivated form. But when we take cephalosporin, this Clostridium difficile, which is present in the colon, will get activated, and it may cause severe diarrhea. Okay, so this is an important concept to know. It may cause, the cephalosporin may also cause GI disturbances, GI disturbances such as your nausea and antibiotic associated colitis. And cephalosporin may also cause sometimes hematological abnormalities. Hematological abnormalities like bleeding and prolonged prothrombin time. And this cephalosporin may cause sometimes headache also. So these are some of the adverse effect of cephalosporin. Uh, when it comes to pharmacokinetics of cephalosporin, let's see about the pharmacokinetics of cephalosporin. So some cephalosporin are given orally, as I already shown in the classification, and some are given parenterally, and some are given intramuscularly or intravenously. Okay, and this first generation oral cephalosporin are well absorbed from the gut. Okay, the first generation are well absorbed from the gut. Okay, then several second to fifth generation drugs like cefuroxime, cefotoxime, cefepime are acid labile. Okay, are acid labile and must be given by parenteral route. Okay, like drugs like your cefuroxime, cefoxime, cefepime. These are acid labile, means they will get destroyed in acidic environment of stomach. So must be given. This must be given IV or any other parenteral route. Okay, or any other parenteral route. So next is after absorption, they are widely distributed. All cephalosporins are widely distributed in the body. Okay, such as your and the drugs such as cefotoxime and cefuroxime and ceftriaxone can cross the blood-brain barrier. Okay, these drugs like they are widely absorbed in the body, and the drug like your cefoxime, cefuroxime and your drug ceftriaxone can cross the blood-brain barrier, so they will be helpful in the treatment of meningitis. And most cephalosporin are excreted primarily by kidney, excreted primarily by kidney, and they have a very short half-life, less than 3 hours, and they have a very short half-life, life of less than 3 hours. But cefixime is mainly eliminated by biliary excretion, so you should remember, other than cefixime, most of the cephalosporins are excreted by the kidney, but this this cefixime is mainly eliminated by biliary secretion. Okay, so these are some of the important pharmacokinetic parameters we should remember about the cephalosporin, and we have to consider some of the clinical consideration. Let's see some of the clinical consideration regarding the cephalosporin, which is very important clinically. So some of the clinical consideration before giving the cephalosporin. So people with the history of urticarial and anaphylactic reactions and anaphylactic reaction, lactic reactions. Okay, people with history of these two anaphylactic reactions should be avoided. Okay, should not be given cephalosporin or penicillin or any carbapenems. Okay, that's beta lactam antibiotics, because it may cause some severe problem. And the microorganisms from the microorganisms such as Enterobacter, Serratia, Citrobacter, Fredi, Hafnia species, Aeromonas species, Proteus species, Providencia species, Morganella species. This group of bacteria have developed some of the resistance against the cephalosporin. So if we give cephalosporin in this type of bacteria, it won't be helpful. So let me name the bacteria for your reference. Enterobacter species, Serratia, Citrobacter, Hafnia, Aeromonas, Proteus, Providencia, Morganella. So these bacteria are resistant. These are all resistant to cephalosporin. So if we give cephalosporin against these bacteria, it won't be effective. Okay, and for high dose treatment or during prolonged therapy, renal function should be monitored properly. Renal function should be monitored properly in case of prolonged therapy. Prolonged therapy should be monitored. Okay, and remember, rapid intravenous infusion may lead to seizure. This rapid intravenous infusion of the cephalosporin may lead to seizure. Uh, okay, And another thing you should know, it may the cephalosporin administration may cause superinfection, chance of superinfection. Okay, so superinfection may occur with prolonged treatment or when the broader cephalosporins are generally used. Okay, and like penicillin, this intravenous preparation of cephalosporin are often incompatible with many drugs. Okay, so this is best to infuse cephalosporin separately. Okay, so it should not be mixed with another drug. Okay, incompatible with many drugs, so it should be given separately, it should not be mixed with any other drug. Okay, and another thing, the last one you should remember is the broad spectrum medicines such as cefotaxime, ceftriaxone, and ceftriaxone may cause vancomycin resistance enterococci colonization. Okay, so it may cause what? Vancomycin resistance enterococci. Okay, VRE in short form. Okay, I will write the full form. Vancomycin resistant enterococci colonization. Colonization. Okay, so this VRE is observed in the drugs such as your cefotaxime, ceftriaxone, and ceftriaxone. So these are broad spectrum cephalosporin, and this VR is observed in this broad spectrum cephalosporin like cefotaxime, ceftriaxone, and ceftriaxone. Okay. With this, I'm going to conclude the cephalosporin. I have taken almost all the aspects of cephalosporin. So I hope you enjoyed the lecture and the information which I have presented here. And please go through it and make notes accordingly. Thank you very much.